Good morning and welcome to the second session of the finals of Medicine Case Presentation, DAMS Medmeet International UG Conference. I am Rishika Anish, student of Government Medical College, Kozhikode, and I'll be the moderator for today's event. Today, we are extremely lucky to have with us a very good judging panel. We have Dr. Krishnadas sir, Associate Professor Neurology, MES Medical College, Perindalmana. Welcome, sir. And Dr. Shamir V.K. Sir, Assistant Professor, Department of General Medicine, Government Medical College, Kozhikode. Welcome, sir. Sir, shall we let in the first participant?
Yeah, sure.
Good morning, chest number 5.
Hello.
Hello.
Am I audible?
Yes,
Yeah.
you're audible.
Okay.
Okay, chest number 5. You have a total of 30 minutes for your case presentation. At 25 minutes, I'll be giving a warning call.
Okay.
Sir?
So, good morning, respected teachers. Can I start my presentation?
Yeah, you can sure, and as early as possible, you finish your presentation so that we can discuss in detail. So after the history, you may take a short break so that we can have a short discussion there. And after that, you can present the examination, and we will summarize together. Okay, Krishnadas, you want to add something?
Yeah, you can go ahead and don't consider this an examination. Okay, just enjoy. It's a learning process.
Sure,
So
sir.
just be normal. Just use your common sense. Okay, we'll together solve this case. Right.
Yes. Thank you, sir.
Okay, all the best.
Coming to the front, sir. So, my patient today is a 49-year-old male named Satish. He's a resident of Kakoti, and by profession, he is a supermarket supervisor. Now, he presents with complaints of vertigo, which was one episode 5 days back, along with decreased appreciation of pain and temperature on the right sided upper and lower limb for the past 5 days, and changing voice for the past 5 days. Coming to the history of present illness, he had a sudden episode of vertigo 5 days back while on his workplace, lasting for 5 minutes, relieved by some sort of medical attention. It was associated with a headache of dull aching type on the left side of the forehead and face. Now, there was no history of any loss of consciousness, vomiting, steadiness, hearing loss, oral fullness, tinnitus, preceding ear infection or trauma to the head. There was also regurgitation of fluid to the mouth immediately after drinking, which was associated with hiccups lasting for 2 days. There was a change in voice as well. The patient could not appreciate hotness of water, that is temperature, in the right hand, and noticed wound marks on the right leg, which he was unaware of. Now, there was, in the negative history, there was no history of weakness of limbs, no history of any facial deviation, no history of urinary incontinence or of seizures, disorientation, speech disturbance, no history of blurring of vision, diplopia, squint, facial sensory symptoms, hearing difficulty, tinnitus, difficulty in swallowing, no history of fever, cough, hemoptysis, or chest pain palpitation as well. Now, sir, coming to the past history, there was no similar episode in the past. He is a known diabetic for the past 5 years. He is on medication. His status of glycemic control is not given. And he is a known hypertensive, which was detected 5 days back, and he is currently on medications. He has no history of dyslipidemia or of coronary artery disease. Coming to the personal history next. He has adequate sleep and appetite, regular and bladder and bowel movement, and he follows a mixed diet pattern. He's an alcoholic, consuming around 30 ml per day for the past 15 years, last consumption 4 days back. He's a known smoker with 7.5 pack years of smoking history. Coming to the family history, he's the second child of a non-consanguineous marriage. He has 2 children and no similar illness in the family. Coming to the drug history, he's taking medications for diabetes and hypertension. It is not mentioned specifically which. The socioeconomic status, he belongs to a middle class family. So that's the history.
That's it.
So
We can stop at this point. Just number 5. We have now 10 minutes for you to discuss the history. So as you know in neurology, you have to go in a, you can take one symptom, analyze it,
Yes.
localize it. Okay. So what you need is to localize the lesion. So first you have
That's
to
the
look
first
for the
step.
functional deficit. It can be this vertigo, and then you have to localize it where it is central or peripheral, just like that. And you need not discuss
Yes.
about etiology. Etiology will discuss in the end. So our idea is
Okay.
to analyze each
First,
symptom
localize the lesion.
and localize it. Okay, so you can
Yes.
start now.
Okay, sir. So can I go back to that slide?
Yeah, first slide.
Yeah,
You
sure.
can you can start
So,
with the
sir,
first.
the patient has three main presenting complaints which will help in localization. The patient has vertigo. He has right-sided decreased pain and temperature sensation, and he also has a changing voice, right?
Right.
So, sir, the vertigo, let's start with the vertigo. The vertigo may be of central cause or of peripheral cause. At this
Very
point, we cannot tell, but
So how will you
in
differentiate
association.
between yeah, carry on.
Okay, sir, so between central and peripheral causes, central vertigo is usually torsional in type, and peripheral vertigo is directional and usually horizontal type, directed towards or away from the site of pathology. Central
So what
vertigo
is
is
this?
not.
Sorry. Let me just. What is this torsional and vertical you are talking about? I didn't get that. For vertigo, vertigo is a
Sir,
feeling of rotation, right?
Or you are
Oh,
confusing with
I'm
something
sorry. I'm
else.
sorry, sir. Yeah, I'm sorry. I
Okay.
confused that with nystagmus. I'm sorry, sir.
Okay.
Okay.
I'm sorry about that, sir. So yes, this patient has a
So
vertigo
how will
which
you
may be
differentiate
No,
central
between
no.
between.
central and peripheral
Yeah.
vertigo?
Okay. Sir, peripheral vertigo is usually associated with severe nausea and vomiting. In
Very
central
good.
vertigo, the feeling of nausea and vomiting is not very prominent, as in this case. So I think this is going towards a case of central vertigo.
Okay, you're right in the sense the vertigo may be more severe in peripheral than central.
Peripheral type.
That is right. But with that alone, you cannot differentiate.
No, sir.
So what are the other things which will help you to think that the one is central and other is peripheral?
Coming to the rest of the history, there
No,
is
you please
no.
tell about the vertigo. How will you differentiate between central and peripheral?
Okay. Sir, there is no any history suggestive of ear involvement, that is
Excellent.
oral
Excellent.
fullness
So yeah, that's it. So if there is associated tinnitus,
No.
hearing loss, and ear discharge, that is in favor of peripheral.
And usually the main causes of peripheral vertigo, that is Meniere's disease and BPPV, are associated with multiple episodes of vertigo. Since we have a single episode, we cannot say that it is a peripheral type of vertigo. It's more going in favor of central vertigo.
Right. So the most important thing in a vertigo is associated symptoms. Okay. The patient has got any weakness or ataxia or any other long tax signs like paresthesias, then that
Absolutely,
points
sir.
to a central cause. Okay.
Yes.
So, and then of course, if there is nystagmus, there is a lot of ways, whether it is fatigable,
Yeah.
okay, whether it is with fixation, it is improving. So with the fixation improving, it is fatigable. Those are suggestive of
Central.
Okay. Now you can go to
Yes.
next symptom.
Yes, sir. Peripheral. Okay.
Right.
So the next symptom that we have is decreased appreciation of pain and temperature on the right side body, both upper and lower limb. So,
Okay.
sir,
Before you start,
hemisensory loss.
can I interrupt?
Yes.
Will that symptom help
Sure,
you to
sir.
assess your vertigo?
Sir, the second symptom, yes, sir, it can help me to localize the cause in the
Very
central part.
Very good.
So, sir, in central causes, it may be due to affliction of the vestibular nucleus, due to the vestibular branch of the 8th cranial nerve, due to the cellular causes, right?
Right.
So
you can now analyze the
I
symptom,
have-
that sensory symptom. You can analyze the sensory symptom.
So the sensory symptom that I have, that is hemisensory loss on one side of the body of pain and temperature, is suggestive of spinothalamic tract involvement of the right side, which has crossed to the left side probably because it crosses around 1 or 2 levels higher in the spinal segments. So probably the lesion is in the left side, and that too, it is quite high up at the cervical cord level or higher.
Excellent.
Now,
Perfect.
sir,
Perfect.
in this case, since we also have vertigo, now these two, matching these two, I suppose that the lesion is somewhere in the brainstem. Provisional diagnostically is some kind of lesion in the brainstem. I cannot say what kind as of yet, but since it is sudden in
Excuse me,
onset, I
it's
would
not.
probably think it is a
Come
vascular
on, second.
etiology.
It's not time to localize
Yeah.
now. You have one more symptom remaining.
Yeah.
Yes, sir.
And
Yeah.
remember, right. And remember, vertigo can be due to anywhere in the pathway of vestibular nucleus or vestibular
Yes,
connections.
sure.
So vestibular spinal collections are there. So even
Yes,
a cervical spondylosis can produce vertigo.
Yes, sir.
So
Absolutely.
at this point, you cannot actually localize it to brainstem,
Brainstem.
but there are certain
Yes.
points which suggest
Around that region, yeah.
Right. Very good. So you mean to say that it's a left-sided spinothalamic
Left-sided
tract
lesion.
involvement? Okay.
Yes, sir.
Right. Possibly in the brainstem. Excellent. Why can't it be in
Possibly in the
Why can't
brainstem.
it be? Why can't this lesion be in thalamus?
Sir, in thalamus, in a lesion of thalamus, we would not have vertigo.
No. From the sensory symptoms alone, why you are not considering the thalamus?
The sensory symptoms alone. Sir, we are considering it in combination, but if we consider it alone, it can be
One
thalamic
second.
involvement.
1 second. Forget all other symptoms. You have only decreased appreciation of pain and temperature on right side of the upper limb and lower limb. Can it be a thalamic lesion? Forget your vertigo, forget the changing voice. Just analyzing the
So it can
sensory
be a
pain.
thalamic lesion, that is Dejerin-Roussy syndrome or thalamic pain syndrome.
Dejerin-Roussy is a positive sensory phenomenon where you get an increased pain. Here it's a negative sensory phenomenon.
It's a negative,
yeah. So that is less likely to be Dejerin-Roussy.
Yeah.
Anyway, the point against thalamus is there is a dissociation between touch and pain. So there is decreased pain and temperature. So that is a point against thalamus. But again, you may get because of the vesicular involvement. But then the face is not involved. That is another clue to suggest that this is not thalamus.
Not at that level.
So that's that though thalamus remains a DD, it is less likely. We will consider spinothalamic tract involvement more likely in view of the lack of phase involvement and the dissociation of pain and temperature from fine touch. Okay, right. Now you can go to the third symptom.
The third symptom is a change in voice. So, sir, specifically a change in voice probably in this case refers to some form of vocal cord affliction. And any problem in the vocal cord is usually, considering the other symptoms, it might be due to involvement of the nucleus of 10th cranial nerve, that is vagus nerve. So, combining all three together, we have a lesion.
That's a very, it's very difficult to digest. So if you have a change in voice, how can the vagus come into the picture? Okay, you can analyze one more symptom which was given.
Yeah. One important symptom is remaining.
Yeah, there is some difficulty in swallowing liquids, and they have not mentioned anything regarding solids. So we will consider that as to be normal. So how will that help you?
That is also suggestive of vagal affliction, and also, sir, they have given a history of nasal regurgitation somewhere during. Yes, sir, this one.
So what are the possibilities of nasal regurgitation?
Nasal regurgitation, so first of all, maybe due to some anatomical defect like cleft palate, but it was not present before that, so we can ignore that. It might be due to local neuromuscular weakness, and it might be due to involvement of vagus nerve.
Very good.
And okay, sir.
So it can be a problem of muscle. It can be a problem of neuromuscular junction. It can be due to myasthenia, right? It can be due to nerve, right?
Yes.
So of which you will consider which one and why?
So I will consider probably vagal nuclear involvement because it's associated with hiccups, which is associated with irritation of the vagal nucleus.
Okay. Okay. So you consider
any other reason for that other than the hiccups?
Considering it as a total with other symptoms, that is, it is more likely to be at the nuclear level.
Okay. So you mean to say there are other long tract signs, spinothalamic tract, and there is involvement of, right. I agree with that. We agree with that, right.
And sir, there's also an absent we haven't come to the examination.
No, we are not going to the examination. So putting all the symptoms together, and each you localize the vertigo to possible vestibular nuclei or its connection. You localize the sensory symptom to spinothalamic tract. And you localize the change in voice and dysarthria and nasal regurgitation to the vagal nuclei.
Yes.
Where will you localize, bringing all of them together? Where does all these things come together? So what is your anatomical localization for this problem?
So this is probably a lesion in the lateral part of the left-sided medulla oblongata.
Very good. Why did you say so?
First of all, we have vertigo. So vertigo does not help in determining the side that much, but we have right-sided upper and lower limb loss of sensation. So the sensations lost are pain and temperature, which usually refers to the spinothalamic tract. Now the spinothalamic tract, after forming the first order neuron at the spinal segment level itself, the second order neuron rises up and crosses to the opposite side, right? So in case of a decreased appreciation of pain and temperature on the right side, the lesion must be on the left side.
Okay.
So that helps me determine the side of the lesion, and combining that with vertigo and voice change, I have localized the lesion to the level of the medulla.
Very
So
good.
suppose it's a lesion in the lateral part of the medulla. Is the history complete? What are the other symptoms you expect, and what are the symptoms missing here?
So the other symptoms I expect are cerebellar signs like ataxia, dysadiadokinesia, which which are absent here. Then, sir, there should also be ipsilateral facial sensation loss. There is no mention of that here.
Okay.
And
can that happen in a lateral medullary syndrome?
Sir, the ipsilateral facial sensation loss is due to the affliction of the lower part of the spinal nucleus of.
Yeah, I got it. I think we are running out of time regarding the history.
Sorry, sir.
So, can that this sort of partial symptoms happen?
Yes, sir. It is possible if the lower part of the medulla is affected. In this case, the trigeminal nucleus will be spared.
Fine. So it can occur with a partial syndromes can occur.
Yes, sir.
So excellent, you are right. And can you just comment 10 seconds? What would be the probable etiology in this case?
Sir, according to the mode of onset, which is sudden, I probably think this is a vascular etiology, and considering the risk factors, that is diabetes mellitus and hypertension, it is going towards thrombotic stroke.
Excellent. So now you can just tell the positive clinical examination finding. Alone. Okay.
Just quickly.
Yeah.
So the important positive, sir, should I say the negative findings?
No need. You have to just tell the positive findings.
So on the skin, sir, we have fresh wound marks on the dorsum and heel of right foot. Patient is conscious, alert, and cooperative. And there are no alterations in the higher mental functions. In the cranial nerve examination, we have asymmetry of the pupils. The left-sided pupil is smaller, so we have a unilateral mucus in this case. And we also have diminished gag reflexes, as evidenced by clinical examination, of which probably involves 9th and 10th cranial nerve. The examination of motor system is unremarkable. The reflex examination is also normal, as well as the deep reflexes and superficial reflexes. The coordination is normal. Primitive reflexes are absent. The gait is also normal. And coming to the sensory examination, sir, pain and temperature, there is decreased appreciation on the right upper limb and lower limb, concording with the history. The fine touch and fine touch is normal. Deep sensations obviously could not be tested. There is no sign of meningeal irritation. The skull spine is normal. And the systemic examinations are also unremarkable.
Very good. So what are the new findings you have got here? And what is the possible localization for it? Is everything going according to plan, or did you get any surprises?
Okay. Sir, first of all, in the higher mental function, there is no derangement. So it goes with my diagnosis. That is, the affliction is not at the cortical level.
Excellent. Very good. Then, yeah.
So, sir, I'd like to say a few things about the general examination as well. So the pulse is 72. There is nothing mentioned about irregularity, right? Okay. So the most common source of an embolus is non-rheumatic atrial fibrillation. So this is actually going against an embolic etiology. We cannot exclude that.
We need not discuss regarding etiology at this point. You can just, that's a good point. That's a good point. You can continue.
Okay, sir. So coming to, so we're done with the higher mental functions. Come to the cranial nerve examination. So, sir, I've observed an asymmetry of the pupil. We have a left-sided mucus. So this is actually going in favor of my diagnosis. That is, probably this is due to involvement of the descending sympathetic tract, which is causing left-sided Horner syndrome.
Very good.
And sir, we have diminished gag reflexes on the left side, which also indicates 9th and cranial nerve involvement. These also help in my localization and go in my favor. Coming to the
motor system, that will explain your symptoms of which are symptoms which will it explain?
of lateral medullary syndrome, sir.
Yeah, which all symptoms in history will that explain 9 and 10th involvement in the form of diminished
That
back?
will explain dysphagia, change in voice, and nasal regurgitation.
Very good, very good. So everything is going according to plan, right?
Yes, sir.
Right.
So
Good.
the examination of the motor system is essentially normal. Now,
Okay.
this means that it is probably a lateral lesion, as a medial lesion would have involved the motor system. So this is again in my favor.
Very good.
The reflexes are unaltered. So the motor system we can indirectly say is not affected. The deep reflexes are normal.
Yeah, carry on. Only the positive symptoms.
Okay. So there are no cerebellar findings. So this actually goes against my diagnosis, but it may be a partial type of syndrome.
Excellent.
So we cannot say that.
Very
yet.
good.
Coming to the sensory system, the sensory examination basically confirms the patient's history. That is, he has a loss of isolated pain and temperature on the right upper and lower limb without any distortion of fine touch, and pressure and joint sensations are not mentioned. But if they were mentioned to be present, then I would have been more confident.
Yeah.
And,
Anyway, touch is normal.
it.
Okay. Right.
Touch is normal. And sir,
So other systems is within normal limit.
other systems are normal.
So
There is no sense of
you
danger.
can put your diagnosis on the table with functional deficit at first, anatomical localization second, and possible etiology as third.
Sir, so this is probably a case of
Functional deficit.
lateral mid. Okay.
Functional deficit first.
This is a case of a patient presenting with vertigo, dysphagia, and right-sided loss of sensations associated with nasal regurgitation. So this is probably a posterior circulation stroke with the lesion in the lateral medulla, and it is probably a type of thrombotic stroke.
Okay, so you think it is a left lateral medullary syndrome, right?
Left lateral medullary syndrome.
Right. Fine. So, what is the possible etiology here? This is a very key question here because
Yes,
you have some clues in this history to suggest a possible etiology. So you think it is a stroke because acute onset and multiple factors. You told that already. I agree with that.
Yes, sir.
What will be the etiology of stroke in this case? There are some clues in this history which suggest a possible etiology.
Yes, sir. So the patient is a known hypertensive and diabetic. So this could probably indicate a thrombotic type of stroke. It does not exclude the other types too. Then, sir, another point in my favor is that this patient had a sudden onset of symptoms. So this indicates something to be likely vascular.
Yeah, all strokes are. I agree with your possibility of stroke. What I want is it a hemorrhage or a thrombotic or an embolic or anything else?
Okay.
There are certain clues.
During the episode, sir, the patient had complaint of mild headache, but nothing very severe. Okay. So this actually goes against a hemorrhagic stroke, and there are no meningeal signs.
Okay, the patient's headache is a significant symptom here. Okay, just consider that it is not mild, it is moderate or severe. How will that affect your diagnosis?
So in that case, I might consider a hemorrhagic type of stroke, or it might also be due to a sudden, in the posterior circulation stroke, a sudden rise of intracranial pressure is also common, especially in cerebral infarction. So
very good. That's a very good point you have told. But I will not agree with your possibility of hemorrhagic stroke because which are the common sites where you get hemorrhagic stroke?
So this is not a very common site. The most common sites are the putamen and the thalamus.
Putamen, thalamus, pons, cerebellum. Okay, yes. So you are talking about lateral medulla, and I am yet to see my first lateral medullary hemorrhage. So very unlikely to be hemorrhage.
Yes, sir.
So anything else which can coordinate? You told a very good point. Posterior circulation strokes, even thrombotic, can produce headache because it's a closed structure, right? But when there is a sudden onset headache at the onset of this lateral medullary syndrome, what will you specify? This is a golden medal question.
It could be a case of
ask me golden medal if you answer it, but this is a very important
this
question.
Could be a case of basilar migraine.
That's too much.
That was an unnecessary answer at this point, isn't it?
Anything else? You are getting there. Any particular cause of stroke, which a thrombotic stroke, which can present with headache, neck pain.
Particular thrombotic stroke.
Yeah.
I'm thinking of
the patient has got some head
hemorrhage
trauma.
With neck pain.
Patient has got a head trauma.
Stroke.
Patient suddenly moved his neck and suddenly he felt a severe pain in the neck, and then patient developed
stroke. That is going towards subarachnoid hemorrhage, sir.
No, you don't forget the presentation. Just from a clue, you don't jump into some other entirely different diagnosis like basilar migraine, subarachnoid hemorrhage. Those things cannot present like this.
Do the deal. Yes, sir.
Keeping in mind your lateral medullary syndrome, you have the localization, the anatomy is clear.
Yes, sir.
Now, sir is asking you think about the etiology. Don't deviate completely away from our functional diagnosis. Okay.
Just keep your cool. This is a very difficult question for you. You have done everything well. That's why I'm asking you. This patient has got a decreased pulse on his hand, for example.
Sir, so this could be a subclavian steal syndrome.
Again, you are deviating.
Sir, any hint, sir?
So how can the headache be explained?
The headache is probably due to a mild increase in intracranial tension, sir.
Okay, have you heard of something called as dissection? Have you heard of something called
yes, sir. Yes, sir. Yes, sir.
So what is the commonest cause of a lateral medullary syndrome?
The commonest cause is occlusion of vertebral artery followed by...
Which vessel is commonly involved?
V4 segment of the vertebral artery.
Okay, so vertebral artery is the commonest cause. Agreed. Second commonest vessel is?
It is the pica. It is posterior inferior cerebral artery.
Excellent, very good. So, what is the commonest disease? One of the common disease in vertebral artery?
Dissection of vertebral artery.
Excellent. So that's what I have been trying to. So how does dissection present?
Dissection presents with sudden onset, severe pain, and then in the neck region for the vertebral artery.
So this patient
there might be inequality of pulses. Okay.
Right. So this patient presented with sudden onset headache. Means we have to suspect dissection. I'm not telling it is dissection. It can be dissection or it can be a thrombotic also. As you told, a posterior circulation can have headache. Okay. Now let's. How will you evaluate this patient? Or what investigations will you do?
Okay, sir. So
since this is a patient. Please, a single investigation which can give you the diagnosis.
Yeah. So if you ask a single investigation, we'll do a non-contrast CT scan. But sir, first we have to do a glucose level of the blood to check for hyperglycemia.
No. You have all the options. You are working in a sophisticated hospital and free of cost. So which investigation will you order?
See, this patient has come within 4.5 hours. You have to be fast.
Yeah, so I'll do an NCCT.
Excuse me, chest number 5.
Hello?
Okay.
Chest number 5, you have 5 minutes left.
Yeah, carry
on. This problem.
You will do a non-contrast CT. Okay?
Yeah. If I have if there is no limitation of resources, sir, I'll like to do a diffusion weighted MRI.
You don't have any. You don't have any limitation of resources.
You have only limitation of
you have is time.
Time.
Yes, sir. So I'll do a diffusion weighted MRI, which will show the infarction earliest at this region. Now, sir, I would like to proceed with our thrombolysis with retiplase. Now, sir, if that works out, then it's all fine.
Will you prefer? Okay, right. You are perfect. CT. Will you prefer a CT or an MRI?
I'll prefer an MRI because it will exactly show the infarction, whereas CT may not show infarction that early. But an absence of hemorrhage is taken as a clinical diagnosis of stroke in this case. And we can proceed.
You're perfectly right. So personally, I will prefer a CT. Because MRI will take more time, 30 minutes.
Okay.
So time is brain.
Yes.
So we'll go for a CT and possible, if there is a CT angiogram, everything can be done in 5 minutes. So if you take a CT, it does not have a bleed, and the MRI shows a vertebral artery dissection or even a vertebral artery occlusion, we will take the patient for thrombolysis. Right?
Okay, sir.
Now, you do a thrombolysis and you do a repeat MR angiogram or CT angiogram, and the vessel is still not open, and you are seeing a complete occlusion of the basilar artery. How will you proceed?
In this case, since the patient, you said it's within 4.5 hours, right?
Yeah.
So, sir,
we did thrombolysis.
If the entire thing is within, yes, sir. If the entire event is within 6 hours, we can go directly for a mechanical thrombectomy. As you said, we have done CT angiography, so we can go for a mechanical thrombectomy. And if it is beyond 6 hours, but within 24 hours, we'll additionally need to do a CT perfusion angiography to know the status of the ischemic tissue. And then we can go for a thrombectomy.
Excellent. So what are the studies which help you guide this decision?
Sir, the 24-hour limit has been set by the Dawn trial. And another is Diffuse 3. Diffuse 3 probably had given 16 hours. I'm not sure about that.
Right. And which are the studies which led you to the mechanical thrombectomy decision? That is for the extended window period. Which are the studies which help you to detect the 6-hour window?
6-hour window, so that's an older study. I don't exactly remember the names.
Somebody from Netherlands who is very clean. Have you heard of Mr. Clean trial?
Probably have, sir. I cannot remember right
excellent,
now.
excellent. You've done exceedingly well. Okay, you've done exceedingly well. These are all the highest. Okay. So the Mr. Clean trial, the Swift Prime trial, everything came in 2016, and it actually changed the way we think about these things. So actually, all these studies are for the anterior circulation, but many of these did a small posterior circulation as well. And right now we have enough recommendations to go for a revascularization of the posterior circulation. So basically, all these studies studied anterior circulation, but they very well do well for posterior circulation as well. Okay, you did exceedingly well. Okay.
Thank you, sir.
Okay. Okay, I think it's time is up. Congrats, you have done very well. The diagnosis is correct. Okay. And we'll see.
Thank you, sir.
After others'
Very
presentation.
nice experience and educational experience with you, sir. So thank you, sir.
Let's invite the next participant. Okay.
Thank you so much.
So coordinators, may I disconnect?
Yeah, sure.
Yes, you can leave the meeting.
Okay, thank you.
Sir, shall we call in the next participant?
Yeah, sure.
Okay, sir.
The previous was test number?
5.
5. Yes, chest number 6.
Good morning, chest number 6.
Good morning.
Okay, can you please switch on your video? Okay.
Yeah.
Okay, hello, I am Rishika Anish. I'm the moderator for this event. You'll have a total of 30 minutes for the whole case presentation. At 25 minutes, I'll be giving a warning call. Sir?
Okay, good morning.
Good morning, sir.
So we'll have a relaxed time. We'll discuss a case. It's not something like an exam. Okay, we had a very good presentation now, and we are too happy to be here. Okay, so you will stop your presentation after the history, and we will have a short break there. We'll discuss something there, and after that you will present the examination, and we will summarize. Okay.
Yes, sir.
So Dr. Krishnadas is also here.
Hi. All the best.
Sir.
Just keep your cool. Okay. So it's a very pleasant learning experience. It's not an exam. Okay, just use your common sense. Forget everything else, and all the best.
Thank you, sir.
All the best. Your time starts.
So I'll start presenting.
Yeah, sure.
Sir, is it seen?
Yeah.
Okay, sir.
You can start. Okay.
Good afternoon. Good morning, sirs. Presenting the case of Sunil. He's a 65-year-old male. He's a cleaner. at the railway station in Papanesheri, Kannur, presenting complaint. Cough for the past 2 months, scanty hemoptysis 1 month, significant weight loss 2 months, pain on the inner aspect of the right arm radiating down for 2 months. No history of fever, purulent sputum, breathlessness, no history of chest pain, syncope, no history of pedal edema. So past history, he had a history of pulmonary tuberculosis 18 years back, 6 months treatment completed, fracture of left leg 3 years back. He was admitted for ischemic heart disease 1 year ago. He has type 2 diabetes mellitus and systemic hypertension for the past 1 month and is on routine evaluation. Personal history. He has normal sleep and appetite, mixed diet, regular bowel and bladder habits. He consumes alcohol half peg daily for the past 30 years, but he stopped 1 month back. He's a chronic smoker. Family history. He's unmarried. His parents are expired. So,
Okay.
hello.
Yeah, that's the end of the history. So you can just summarize and you can tell us how you analyze the history.
Sir, 64-year-old male.
Yes.
He presented with cough, significant weight loss, and pain on the inner aspect of the arm radiating down for the past 2 months, and scanty hemoptysis for the past 1 month.
Okay.
He had a past history of tuberculosis.
Yes.
18 years ago, he completed 6 months treatment. Fracture of the left leg 3 months ago. He had a history of ischemic heart disease 1 year ago. He's a chronic hypertensive and diabetic patient and is on routine evaluation for the same.
Okay, you just try to analyze the history, each symptom by symptom.
Okay. So first, he came with cough with scanty hemoptysis. The cough is non-productive, but it is present for the past 2 months. There's no associated fever. He's not complained of any fever. He has significant weight loss for the past 2 months.
Okay.
Then he has pain in the inner aspect of the tongue, radiating downwards.
Okay.
Sir, first, when I
You can analyze cough with hemoptysis. What are the causes of which one will you consider first here because of the coexisting other symptoms? That's the way to go.
Yes, sir. He has cough and hemoptysis. Cough and hemoptysis, there are infective causes like tuberculosis. He has a past history of tuberculosis. Then bronchiectasis, lung abscess. Then
when you enumerate the causes, we would consider it as you are considering those cases here also. Is it that way? Or
no,
you are
no,
just
sir, no,
telling us the causes of cough? You did not enumerate the causes of cough here. What are the possibilities you consider in this patient? Are you considering a bronchiectasis here?
No, sir.
If not, you need not mention bronchiectasis. Okay, only the conditions which you consider in this patient.
In the
Otherwise,
order of preference, considering the coexisting symptoms, in the order of preference, what do you think is the most common cause of hemoptysis with cough in this patient? You can use the associated symptoms as the clue.
Yes, sir.
Okay.
Sir, he has cough and hemoptysis. So firstly, I felt he has significant weight loss. He does not have associated fever. So it could be a carcinoma, bronchogenic carcinoma.
Okay, very well possible.
Then, because he even has pain inner aspect of right arm radiating downwards.
How does that contribute? How does that contribute to your diagnosis?
Sir, if he has a pancreas tumor in the upper lobe of the lung, it could a component of it is pain at the inner aspect of right arm radiating down if it compresses the brachial plexus.
Okay. So what other symptoms will you like to ask this patient to get more details of the pain.
More details of the pain. Did it start gradually?
The duration is almost given here. It's 2 months duration. What other
Yes, sir.
quality of the pain you would like to ask? If you are given the patient and you are given a chance to take a history, what additional things would you ask?
Is the pain? Is it a shooting type of pain? Is it
Okay, very
increasing
good,
on
very good.
coughing?
Okay.
With straining of stools.
Okay. What sort of pain it is called?
Radicular pain.
Radicular pain. Very good, very good. Okay. So you are considering these symptoms together and you are considering a bronchogenic carcinoma. What else? Any other possibility?
So tuberculosis.
Okay. Why?
Because he has a past history.
Okay.
And because he has cough, hemoptysis for 2 months.
Okay.
Then he has significant weight loss as well.
Okay. Any other history in the past or personal history? Anything would help you to arrive at a diagnosis?
In the history, he's a chronic smoker. So then he has hypertension, diabetes, comorbidities, and
Okay,
So,
if it is TB, how can you explain that pain around the inner right arm? Can you explain
Sir?
that? Can you explain the radicular pain with TB?
With TB, if there is fibrosis, but it won't.
it won't produce pain.
It's not a growing lesion. It's a fibrosis. So I don't think it will compress. I am not sure, sir.
So,
TB can have lymph node, right? TB can have lymph node. It can affect
Yeah, lymph
spine.
nodes. Yeah,
Okay, it
yeah.
can affect the spine, pot spine. Okay, not a common side
Yes.
surgery, but still,
Yes,
by number of ways it can affect, right?
can
Yes,
the
yes.
past history of tuberculosis still contribute to a malignancy? Because you have a history of tuberculosis in the past, you are considering tuberculosis now also. My question is, since he has a tuberculosis in the past, can it be still a malignancy because of that?
Maybe, sir. I'm not sure.
Okay.
Sir,
Okay.
I'm not sure.
So, okay, let's go to the examination.
Any other DDs you want to consider other than this thing, malignancy and TB?
So any lymph nodes could compress the.
Yeah, I'm not talking about the radicular pain. Any other DDs other than for this cough hemoptysis, other than malignancy and TB?
There could be metastasis and then mediastinal lymph nodes.
Yeah, malignancy, we brought it together, right? Any complication of a old TB producing certain other infection which can produce severe massive hemoptysis?
So I don't remember.
The balls or something? Some football or
Aspergillus.
Okay.
Okay.
Right. So cavitating lesion with the Aspergillus ball, right? Okay, fine.
Yes.
Okay. So let's go to the examination and find out.
Yes.
Okay.
So on general examination, patient is conscious, oriented, and cooperative. He's comfortable in the supine position. He has a height of 164 centimeter, weight 55 kilogram, with a body mass index of 20.45 kilogram per meter square. Pallor is present. There is no icterus, no cyanosis, no clubbing, no lymphadenopathy or edema. Hyperpigmentation was seen over the left ankle. Koilonychia, dystrophic nail changes.
I think it's written clubbing is present, isn't it?
Clubbing. Sorry, sir. I saw the comma. Sorry.
Okay.
Yes, sir. Sorry, I read fast.
Okay.
Pallor no icterus, cyanosis, clubbing is present. No lymphadenopathy or edema. Hyperpigmentation over the left ankle. Koilonychia, dystrophic nail changes present in both feet. No thyroid swelling. No varicose veins. Vitals, pulse rate 70 per minute. So nothing else is written, so I'm not mentioning. Left dorsalis pedis artery and posterior tibial artery pulsations are absent in the left. Then a respiratory rate 20 per minute. Blood pressure 110/70 millimeter of mercury in the right upper limb in sitting position. He is febrile to touch.
You can tell the positive findings. Okay.
Sir, of general examination or
No. You need not repeat in the respiratory
sir.
system.
In the respiratory
Okay, sir.
system, you can just tell the positive findings. Okay.
So that
Multiple
we can
keloids.
save time.
Yes,
Okay.
sir. Multiple keloids were seen over the central chest on inspection. On palpation, trachea shifted to right, epic speed not palpable. Chest wall movement was decreased on the right side with total expansion 2.5 centimeter, but right hemithorax expansion was 0.5. Left hemithorax was 2 centimeter. Tactile vocal fremitus was decreased on right supraclavicular and infraclavicular areas. On percussion, dullness was obtained over right supraclavicular area, infraclavicular area, and right suprascapular area. All the other lung areas were resonant. Liver dullness was obtained. On auscultation, decreased breath sounds in the right supraclavicular, infraclavicular, and suprascapular areas. Scattered expiratory rhonchi were present. Decreased vocal resonance was seen over right supraclavicular, infraclavicular, and suprascapular areas. The other areas were all normal. Other systems, nervous system examination, right eye partial ptosis with the right pupil being smaller than the left, that is meiosis. Then on gastrointestinal system, liver was palpable 3 centimeter below the coastal margin. So,
Okay.
done.
So now, what are the
Yes.
additional points you got here?
My sir, on inspection, the trachea appeared central, but on palpation, trachea was deviated to the right.
Okay.
Then there was reduced
What are
chest.
the conditions you expect then? When the trachea is deviated to right, what are the possible explanations?
There could be a collapse of the same side or a fibrosis of the same side. It will cause tracheal deviation to the same side. In not in this case, sir, but in general, if there was a pleural effusion or a pneumothorax on the left side,
you need not consider other causes which you are not considering in this patient. General
yes, sir.
causes are not required here. Only
Yes,
with respect to our patient, what are the possibilities? So it can be a collapse or fibrosis of the
right
right.
side.
Okay.
Yes. Then
And
decreased chest movements. Sir?
Can it be a normal finding also? Trachea shift to right?
Yeah, if it is, there is a slight shift in the trachea normally, but
okay, you take it as abnormal here. Okay.
Abnormal finding.
Okay.
So then,
Why do you take it as abnormal here?
So because the history is abnormal, then there are other findings on the right side of the chest on respiratory system examination.
Very good.
Then there was decreased chest movements on the right side. Hemithorax expansion.
When a patient is having decreased movements on the right side, what is the inference?
Inference, the full capacity is not there, so it could be a collapse or a fibrosis.
Okay, it can be any pathology on that side. That's all.
Yeah. Yes, sir.
Okay.
Then to that, just so 1 second, sorry. The hemithorax expansion was 0.5 centimeter. It was decreased.
Okay.
The other side was comparatively normal, so we can say for sure that the pathology has to be in the right side of the right lung.
Okay.
Then tactile vocal fremitus was decreased in the right supraclavicular, right infraclavicular area. On percussion also, dullness was obtained in the right supraclavicular, infraclavicular, and suprascapular areas.
So what are the possibilities now?
Sir?
What are the possibilities now till this point? You have a decreased resonance there. You have a decreased vocal fremitus.
Yes, sir.
Okay, then what are the possibilities?
decreased vocal fragmentus and decreased resonance. Again, I think it could be a collapse.
Collapse of
The upper lobe, right upper lobe of the lung.
collapse of the right upper lobe. Okay, continue.
So then other lung areas were resonant. On auscultation, diminished vesicular breath sounds were seen in the same area, and there were scattered expiratory rhonchi present as well.
Okay.
So, sir, it could be maybe because the obstruction is not complete, or maybe because he has an underlying chronic obstructive pulmonary disorder.
Okay.
If expiratory rhonchi are being seen.
Okay, that is generalized, isn't it? They
Yes,
are
sir.
not describing any particular area for the rhonchi. So if
No,
it was
sir.
a fixed occlusion, you should expect a
Localized.
Localized. Okay, localized. Okay, this is a scattered expiratory rhonchi. So most probably it's due to an underlying
Obstructive pulmonary disorder, chronic obstructive pulmonary disorder.
Okay, very good, very good. Then
so then on examining the other systems, when you came to the nervous system, there was right eye partial ptosis, meiosis.
okay.
So again, it could be because of a Horner syndrome, because of the Pancoast tumor compressing the cervical sympathetics.
So you are also getting some findings of an Horner syndrome.
Yes,
okay.
sir.
Okay. So correlating all these things together.
Yes, sir.
Anything else? Any other positive findings you missed out? Nothing. Okay. So you can correlate all these things together.
Yes, sir.
And gastrointestinal system, there is one finding, isn't it?
Yes, sir. The liver is palpable. Mild hepatomegaly is seen.
Okay. Okay. So
there could be a metastasis to the liver, or
no, you correlate all the findings together.
Okay, sir. Sir, I believe the system could be respiratory system.
Okay,
It could be a right upper lobe of the lung collapse, probably due to a bronchogenic carcinoma. It could also be due to a mediastinal lymph node compression. There is associated Pancoast tumor syndrome, as seen by the right, the pain radiating down the right inner arm, as well as there is Horner syndrome signs were present. Then, and etiology is a chronic smoker. He's a alcoholic as well.
So how can a Pancoast tumor produce a collapse? What is the location of the Pancoast tumor usually?
Upper lobe of lung, sir.
Upper lobe means the whole upper lobe, or?
Apex.
Okay, so what is the mechanism of collapse in a bronchogenic carcinoma? These two things are different, isn't it?
Yes, sir. Yes, sir.
So
in the collapse, because of the bronchus is obstructed, of the bronchus leading to the right upper lobe.
So it should obstruct a bronchus, isn't it?
Yes, sir. Yes, sir.
Okay, okay. So you are suspecting a Pancoast tumor obstructing a bronchus.
No,
Is
sir.
it so?
No,
Then,
sir. No,
then how?
The Horner syndrome is present, so I felt, but the bronchus obstruction could be due to lymph nodes.
Okay, something else, or it's a very big lesion or something like that, isn't it? It's
yes, sir.
difficult to explain. Okay, okay. So suppose the patient is given to you. Okay, you have not seen the patient, isn't it? So many things may be incomplete. So you are given a chance to examine again. So you are doing the general examination. What are the specific things you will look for, which are not mentioned in our case?
So general examination.
Don't mention any findings which is already given. No, clubbing is already given in here.
Lymph nodes, sir.
Lymph node, it's given. There is no lymph node enlargement.
Yes, sir.
No, I am not asking you to counter check the findings. I am asking you to mention the findings which are not given here.
Okay, sir.
Your diagnosis is Pancoast tumor with
Yes,
the
sir.
collapse, right
Yes,
upper
sir.
lobe, and owner
Yes, sir.
syndrome. Okay.
Yes, sir.
So we can again examine the patient to look for any other evidences which can favor our diagnosis.
So jaundice.
How does that help?
So the liver, they said it's palpable. If it is to confirm whether the liver, it's really metastasis of this particular cancer.
If it's not metastasis, what else will you consider? A viral hepatitis also.
No, sir. No, sir.
Okay, so that won't help us much, isn't it? If
Yes.
you pick up a jaundice, you will have to think of entirely different possibility.
Yes, sir.
So you can look for some findings which can help to diagnose our condition, isn't it?
Yes, sir.
Okay, so
Sir,
indirectly, what are the
myopathy.
other general examination findings you can get here? I was asking the same question indirectly. Now I am putting the questions straightforward. What are the other general examination findings you can expect in a patient with bronchogenic carcinoma? Very straightforward.
Sir, myopathy.
Okay.
Then
Maybe Shraddhas is
the
happy. Okay, myopathy is.
sir, bilateral ptosis.
Why bilateral ptosis?
Sir, paraneoplastically there might
Paraneoplastic,
be.
very good. Paraneoplastic manifestations you can expect. What are the common paraneoplastic manifestations you can expect in a bronchogenic carcinoma?
Sir, there will be there can be Lambert-Eaton's myasthenic syndrome.
Okay, very good, very good. Okay.
There can be cerebellar degeneration,
Okay.
myopathy,
Okay.
then dementia, then
So
ectopic
she's
ACTH
going to become a
secretion.
neurologist. No
Sorry.
doubt. Only neurological answers. Okay.
No, sir. Ectopic ACTH secretion.
So how can you pick that ectopic ACTH secretion by general examination?
General examination.
Okay,
So
general
blood
examination
pressure.
or other. Oh,
Blood pressure, hypertension.
hypertension. Okay. What are the skin manifestations of a internal malignancy?
There will be hyperpigmented patches can be seen. Hyperpigmentation patches can be seen all over the body. Maybe over the chest more.
Yes.
Then
is there any named hyperpigmented patch which can be associated with an internal malignancy, which is given some name?
so this malignancy or general?
In anyone?
So lesser sign seen.
Means seen in which malignancy?
GI malignancies.
Okay. In bronchogenic carcinoma, can you get any such manifestations? So suppose a patient is having clubbing. Okay, forget the skin also. So what additional things will you look for when you suspect a bronchogenic carcinoma? Already patient is having clubbing.
Yes, sir.
What additional general examination finding will you look for? Along with clubbing, what else? Bronchogenic carcinoma.
Nails.
You already looked at the nails and you have picked up clubbing.
Yes, sir.
What is next to it? The
Cyanosis.
highest grade of. What is the highest grade of clubbing?
Hypertrophic osteoarthropathy.
Okay. Where will you look for that?
The wrists and.
Okay, very good. So that is one side. Okay, the patient is already having something like a root pain in the radiating down. What else will you look for there? Patient is having, you are suspecting a Pancoast tumor. Patient is having an owner syndrome. He is typically telling you he is having a radiating pain down the inner aspect of the arm. So you are expecting a brachial plexus involvement also. So what will you look for there? In examination, will you look for any specific abnormality?
Claw hand or any other wasting of the arm muscles.
Which muscles?
Thenar and hypothenar muscles.
Okay.
Test number
Small
6.
muscles of hand. Okay.
5 minutes left.
And in the neck, what will you look for? If there is a bronchogenic carcinoma,
Yes, sir.
you are suspecting a bronchogenic carcinoma, and what will you look for in the neck of the patient? Some important finding.
Supraclavicular limb.
I expected nodes. Okay, nodes we have already by inspection.
In bronchogenic carcinoma, sir. I don't know, sir.
Bronchogenic carcinoma, mediastinal mass, or lymph node, anything like that. You
So
are mentioning
mediastinal widening, you can look for it like
make out in
percussion.
You can make out in percussion or X-ray. And if there is
Yes,
a
sir.
mediastinal compressing tumor, you may get a very important clue by looking at the patient's neck. That's a very important finding.
Supraclavicular.
So you can have paraneoplastic manifestations, you can have some compressive manifestations, and you can have metastatic manifestations, and you can have some local effects in any tumor. It's something like that. So you have some local manifestations here you have picked up. You have some compressive manifestations that you have picked up, like the pain, radiating pain, that is because of the compression. And you are having some compressive features like Horner syndrome. And metastatic manifestation you can get like hepatomegaly. Paraneoplastic manifestations like cerebellar or Lambert-Eaton, something like that. So one important compressive manifestation which you have missed. Very important.
Which you is looking at the neck.
It is compressing on some vital structure.
Superior vena cava. It could compress the superior vena cava. You could get dilated veins.
What is the peculiarity of those dilated veins? What is the difference between a congestive cardiac failure?
A congestive cardiac failure, you will get a pulsatile JVP. Superior vena cava syndrome, it will be non-pulsatile, and there will be bilateral and no, not bilateral. Sorry, this is only one side.
Okay, how will you investigate this patient?
First, a chest X-ray, sir. To chest X-ray along with complete blood count, ESR, CRP. Then he has anemia, so hemoglobin, all the indices, MCV, MCH, MCHC. Then on chest X-ray,
specific investigations.
Bronchoscopy to take a biopsy to determine if it is a carcinoma, what type of carcinoma, if it's
having a pancreas tumor.
Yes, sir.
So you do a bronchoscopy or something else first?
Yeah, anyway, it is compressing on the bronchus.
Because there is a collapse.
Yes, sir.
Right.
So it's easily accessible.
Okay. Right.
Okay.
Then what is the cause of Horner's in this patient?
So sympathetic chain is obstructed.
Okay, so what are the parts of sympathetic Horner's? What are the first order, second order, third order?
First order, it starts from CAT1, and then it that is the first part, but Horner's affects the second part when it moves to the superior cervical ganglia.
Is the first part?
Sorry, sir.
Okay, I think we are running short of time.
Yeah.
Right.
Okay, thank you. Very well presented. Very good diagnosis. You have reached the final diagnosis. Okay, very good case also. Okay,
very good presentation.
Congrats.
Thank you, sir.
Thank you, test number 6. You may now leave the meeting. Sir, shall we let him participate?
Right.
എവിടെ പോയി? ആ വേണം.
Good morning, chest number 7.
Good morning.
Hello.
Can you switch on your audio?
Hello.
Ah, yeah.
Yeah.
Can you
morning.
hear me? Good
Yeah,
morning.
sure.
Good morning, sir.
Okay, are you ready?
Switch on the light.
Oh,
Simple.
1 minute.
No problem. The screen will be okay, isn't it?
Hello.
Yeah.
Hello.
Yes.
The light is on, but your head is below the camera. Oh, okay, now we can see. Okay, thank you.
Yes.
Nice
So,
meeting you.
chest number 7.
Yes.
You have a total of 30 minutes. At 25 minutes, I'll be giving you a warning call.
Okay. So we have planned like you will present the history first, and we will have a short break. We'll discuss the history, then the examination findings, and then again we'll have another set of discussion. Okay.
Okay, sir.
So hope you are ready. You relax, and you can have a nice
Yes,
time.
sir.
Okay.
I'll start
Shall I-
sharing.
You can start. Yeah, you can start sharing. All the best.
Yes. Very good morning to one and all. I'm Sufyan Ibrahim from Kasturba Medical College, Manipal, and I'll be presenting the case number 3 today in the DAMS Medmeet medicine case presentation. Mr. Ravin, a 65-year-old gentleman hailing from Malappuram, presented to the hospital with chief complaints of weakness of bilateral lower limbs since the past 3 days. This weakness also had weakness of upper limbs since the past 1 day. 3 days ago, he noticed difficulty in standing position from squatting position, which gradually progressed over the course of the day, and he was unable to move bilateral lower limb. Since morning, 1 day on the day of admission, he also noticed weakness of bilateral upper limb. Paresthesia is also noted in both upper as well as lower limbs. There's no history of bowel and bladder involvement. There's no history of seizures, loss of consciousness, or headache. No history of similar complaints in the past. There's no history of trauma or low backache. No history of diarrhea, fever, or immunizations in the recent past. He's a known hypertensive since the last 10 years and is on treatment for the same. He has been admitted 8 years back for a CAD, which was managed conservatively and details of which are not known. There's no history of similar episodes in the past. Personal history: he consumes a mixed diet. His appetite is not reduced. Bowel and bladder habits are regular. He was a smoker for 25 years, but he has quit smoking 10 years back. He has no other addictions. That's the history.
Right. So, as in any neurology case, you can start with first symptom, analyze that symptom, and localize it. Okay. We don't want any etiology. We just want analysis of the symptoms and the possible clinical localization.
Okay.
So, you can start with your first symptom.
Okay. He presented. Rain presented to the hospital with chief complaint of bilateral lower limb weakness, and it was followed by bilateral upper limb weakness. So this is a case of acute onset weakness of both upper as well as lower limbs,
Okay.
where the weakness was progressing from below upwards. So it's more like a presentation of acute paralysis, which is of ascending type. 3 days ago, when he noticed weakness, which was gradual from getting up from squatting position, so it indicates more towards a proximal muscle weakness involvement more than
Right.
distal muscle involvement.
Okay.
And since it is a symmetric involvement of both upper as well as lower limb, it gives an etiology of symmetric acute onset flaccid paralysis.
Why do you say flaccid?
Sorry, that is based on the other features which I noted on exam. So as of now, it is symmetric acute ascending paralysis.
Okay.
He also complains of paresthesias in both upper and lower limbs, but no other sensory complaints was given by the patient. Now, there is no history of bladder and bowel involvement.
Yeah, before that, where will you localize the lesion? So there is somebody with a weakness. So what is the first question? First question is the patient having a organic problem or it's a psychogenic? Do you think it is organic or is it just a psychogenic problem? Is there a
Sir,
problem?
this looks like a very definitive or
There is a
organic
significant
problem.
problem. There's no doubt, right? So
Yes,
there
sir.
is a weakness. So how will you analyze his weakness? Where will you localize his problem? What is the
Sir,
cause of his weakness?
um, depending on the presentation, it can be at the level of spinal cord, since both upper and lower limbs are involved.
Okay.
Um, it can be at the level of nerves, that is, it can be polyneuropathies, since
Right.
there is also
So
complaint of.
let's put it in a simple way.
Yes,
So
sir.
there is a weakness means it can be either a upper motor neuron weakness or a lower motor.
Lower motor.
So the first question you want to ask yourself is it upper motor neuron or lower motor neuron? Which one will you consider first? Which one will you consider second?
I would consider upper motor neuron first in this case,
Why?
because it was acute onset weakness, which usually we have to rule out stroke in such patients.
Okay, which so we are not going for etiology anyway,
Yeah.
but because you told it is stroke, which stroke produces a quadriparesis?
Sir, usually pontine strokes, pontine hemorrhage, or bilateral uh,
So
involvement.
a pontine hemorrhage can produce weakness of lower limb on 1 day, 3 days later, weakness of the upper
No,
limb.
whenever you discuss, you have to stick on to our patient. Okay,
Yes.
don't generalize so widely. So
Okay.
always when you answer, you have to consider our patient first. Okay.
Right.
Okay.
So you don't consider pontine because you don't get any cranial nerve symptoms from your history. So you're not
Yes, sir.
considering that. So I agree that you can think of UMN. There's no problem. So what are the where in UMN you will consider and why do you consider UMN first?
Okay. Sir, here the history is acute onset and bilateral involvements. Uh, and also there is no history of involvement of sensations. So,
There is paresthesia. Patient has got paresthesia, right? There is
yes,
sensory
sir.
involvement. Okay.
Yes, sir.
So if you are considering a UMN, where will
Yes,
you localize them?
sir.
What is the localization possible in our patient if the weakness is of a UMN type?
Sir, at the level of cortex, involvement of cortex.
Which part of the cortex?
Um, Sir, the motor cortex, precentral gyrus.
Which motor cortex, right side or left side?
Sir, most likely it is left side, but it can be bilateral involvement.
How left side can produce a quadriparesis? We are dealing with a quadriparesis. Don't forget our patient. That is why again and again I am repeating.
Yes, sir.
Don't completely move away from our patient.
Okay, sir.
Okay, so this is very unlikely to be a cortical problem because you have to have two different lesions, no? So
Yes,
whenever
sir.
possible, okay, it's quite possible the patient has got bilateral brain abscess and motor cortex, but the chance of that is very less, very unlikely, right? So you have to
Yes.
use your common sense. There is no cortical features, there is no brainstem features. Somebody having a quadriparesis, where is the possibility without cranial nerves, without higher function abnormality? Where will be the possibility? UMN.
Sir, spinal cord level,
Excellent.
sir.
It's a high cervical cord
Which
lesion can explain your problem. Okay.
Yes, sir.
So, is there any human science to say that? Or
Uh, in-
will you consider element possibility as well?
yes, sir. We consider element possibility because there is no definitive upper motor signs like um, spasticity in this patient.
Right. You're
so
right. You're
which
right.
one
But there
first?
is a problem
Element or
there. There is
UMN?
a problem there. In acute onset syndrome, it might be a spinal shock state. So you may
Yes,
not
sir.
get the classical spasticity, heaviness of limb tipping or fine obstacles. All this history may not be available.
Yes,
But so you can very much be a element sort of finding. What is if there is one particular finding in that negative history, you would have think of UMN more likely. I will consider element more likely because of the absence of that finding. What is that? Somebody with quadriparesis, which is the negative history here, which suggests this is more likely to be LMN.
sir. Absent of bladder and bowel involvement.
Excellent, excellent. So absence of bladder and bowel push it more towards LMN. We cannot be sure. It can still be a UMN lesion or an LMN lesion. Because in this acute setting, a spinal shock like scenario look like just like an LMN. But because the bowel and bladder is not there, you have to think of LMN as well, right? So
Yes.
if in LMN, what are the possibilities here?
Sir, this could be because of polyneuropathies,
So what are the
likely
components of LMN? So how will you
Sir,
analyze an LMN case?
element starts from the anterior horn cell in the spinal cord,
Right.
then the motor nerve, then the neuromuscular junction.
Before that, so it
How does
starts
the nerve form?
cell, then it forms the root, then it forms the plexus, then it forms the peripheral nerves, then it forms the neuromuscular junction and muscle. Though LMN muscle is not there, we will consider it as a part of the syndrome. Of which all will be ruled out in this case?
Sir, we can rule out the neuromuscular junction and involvement here because only upper and lower limbs are involved. But usually in neuromuscular cases, even small muscles of the eyes, of the hand, all those will be involved.
Okay.
We can also
I'll give you a clue. There is some paresthesia here. Will that help you to localize an element?
yes, sir. Since there is paresthesia, we'll have to think of the peripheral nerve level more than.
How does it help to rule out? Which conditions will be easily ruled out by this symptom?
In element.
We can rule out myasthenia gravis or other muscle disorders because of presence of paresthesias.
Okay.
Then anything else?
We can, apart from that, we can rule out spinal cord compression.
Element, so you can rule out muscle, you can rule out neuromuscular junction, you can rule out anterior horn cell because this is a pure, this is not a pure motor syndrome. All these three are pure motor syndrome. Because the patient has paresthesia, we can rule out anterior horn cell, neuromuscular junction, and muscle. What is left?
The peripheral nerve. Sir.
There is peripheral nerve. Very good. Then
the plexus and the nerve root.
Nerve root. Of which anything else you want to rule out? Of these three, anything else you want to rule out?
Sir, plexus involvement is usually unilateral.
Yeah. Very good. So plexus is very unlikely to be. It's usually unilateral. Now here you can get. You have to get two brachial plexus and two lumbosacral plexus together to have a plexus. That happens only when you are fired with an AK-47. Okay.
Multiple times.
So that is unlikely. So it is not plexus. So all things what is left is it can be a multiple peripheral nerve problem or a multiple root problem.
Yes.
Okay. So which disease can have that sort of involvement? Or of which one will you consider first? Root or a nerve? Peripheral nerve or a multiple root?
Sir, I would consider peripheral nerve first.
Why do you consider that in this case?
Because of symmetric involvement of both lower limbs and both upper limbs and presence of paresthesia.
Okay, so root can also have that symmetric involvement. But peripheral nerves, usually what is the pattern? Is it proximal or distal more?
Peripheral is distal to proximal.
So it's usually length dependent neuropathy. So would you want to reconsider your diagnosis? Is it peripheral nerve more or root more? More likely to be root.
Root.
Okay, it can be a polyradiculopathy. It can be a polyradicular neuropathy where roots and nerves are more affected. Why do you think so?
Sir, because of symmetric involvement of both upper and lower limbs.
Yeah, there is more of a proximal involvement that is in favor of a polyradiculopathy more than a polyneuropathy. Okay, so which is that disease which can present in 3 days as a progressive weakness of lower limb followed by upper limb with multiple root involvement and maybe nerve involvement as well?
Sir, acute inflammatory demyelinating polyneuropathy.
So GPS is one good possibility here, right?
Yes,
so that is, I agree with you. What will you consider as a second possibility in this case?
We'll have to rule out other causes of ascending paralysis. Like
you need not discuss the etiology. I think polyradicular neuropathy or polyradiculopathy, I agree as the first diagnosis. The etiology being GBS. You don't discuss GBS etiology. You just think it is polyradicular neuropathy. Which will be your second DD? Is it a peripheral neuropathy as a second DD or UMN? You want to keep UMN as a second DD? If in UMN, which is the lesion?
I would keep peripheral neuropathy second.
Okay. The problem against that is the patient has got a proximal more than distal. It's less likely, right? Okay.
Yes.
Okay. Sometimes what happens is severe peripheral neuropathy is known as confluent neuropathies, confluent mononeuritis multiplex. Severe vasculitis can present something like this. Anything else you want to keep in mind? Other anatomically, you want to keep UMN? You told us UMN first. disability. Which human disease can present like this?
Sir, bilateral involvement of the both hemispheres of the brain uh, due to abscess.
Oh my God. I was making a joke.
Well picked up clue.
I was making a joke. So, very unlikely to be a hemispheric lesion or a brainstem lesion because you didn't get any cortical features. There's no aphasia, there is no apraxia, there is no cortical feature, there is no brainstem feature. So, you get to keep it at high cervical cord, right?
Yes.
So, high cervical cord, what can be the possible lesion? There is no bladder. Is that possible?
Sir, in cases of atlantoaxial instability,
Okay.
high cervical cord can be involved.
Very good.
Uh,
Then,
in cases of spinal syrinx in the spinal cord,
okay, but that is a slow progression. Very rare to have syringe presenting acutely, though it can occur.
or because of compression of the spinal cord at upper cervical level.
Correct. Correct. So a compressive lesion can have a bladder involvement, which is early or late.
Early onset involved.
Compressive.
Which type of compression?
If it's from outside to inward, the bladder is involved last.
Okay. So I agree with your possibility of a CVJ anomaly. Suddenly there is a compression on the spinal cord, and it's not good enough to produce a bladder involvement. That is quite possible. That can explain the motor sensory, and in a spinal shock sort of scenario, you can get all these findings. So that is fine. So your DDs will be a polyradicular neuropathy in LMN, and maybe a severe peripheral neuropathy as second DD. And in UMN, your possibility will be a high cervical cord lesion. Etiology we don't discuss. It can be compressive. It can be a demyelinating, patchy demyelinating sort of thing, which is not a transverse myelitis. And the bladder fibers are somehow spared, which is very common in a long segment demyelination like NMO or something like that. So your possibilities first will be polyradicular neuropathy, second will be peripheral nerve, and third is a high cervical cord lesion. Are you agree to that?
Yes.
Okay, so you can go to the examination now. You can tell only the positive findings. Okay.
Okay. Sir, on examination, the pulse was 82 and blood pressure was 140 upon 90. He was conscious, oriented to time, place, and person. There was no pallor, ictus, cyanosis, clubbing, lymphadenopathy, or edema. On central nervous system examination, the higher mental functions were normal. On cranial nerve examination, there was bilateral facial weakness present. All other cranial nerves were within normal limits. Motor system examination, the bulk was normal bilaterally. Examination for power, the upper limb showed proximal muscle power of 3 by 5 in both right and left side, and distal muscle of 4 by 5 in right and left side, and lower limb was of grade 1 by 5. Tone was decreased in all four limbs. There was no fasciculations. On reflexes, the ankle as well as knee jerk reflex were absent bilaterally, as well as diminished upper limb reflexes were noted. Plantar reflex was flexor plantar response bilaterally. Sensory examination was within normal limits, no cerebellar or meningeal signs.
Right. Are you happy?
Yes,
After
sir.
examination, have things gone according to your plan, or are you surprised?
No, sir. I am happy.
You're happy.
Yes.
See, if I am the casualty man, I am be really happy because I have got my classical one clue to make a diagnosis.
Yes.
So, what do you think? Is it UMN or LMN? Why?
Sir, I think it is LMN because on examination there was decreased tone in all four limbs,
Okay,
which
hypotonia
indicates
in favor of LMN, right? Agreed.
and reflexes were completely lost in lower limbs and diminished in upper limbs, and
So
plantar.
suppose one second. Suppose it was a human lesion due to a high cervical cord lesion,
Yes, sir.
and it happened in 2 or 3 days. What
Yes,
would
sir.
be the findings you expect then?
Sir, in 2-3 stages, we'll have state of neuronal shock. In that stage, also we can get flaccidity.
So
So
it's not
this
yet
don't
type.
really help you. Like, this don't really make you happy. It can still be a
Still, there are two possibilities.
Yes, sir.
Okay,
So what is
carry
the
on.
thing here? What is the thing here? Okay. Yeah. What else? What else you make it element?
Sir, reflexes were absent and plantar was flexor
Yeah, that's
bilateral.
a very good point because already the patient has got severe weakness. So if it is even as a spinal shock, you can get a mute plantar. So it going flexor in a weak limb is very much in favor of a element.
Element.
Agreed. Then what else? What else?
Sir, in muscle involvement, it is proximal.
Yeah,
Muscle
that's a very
weakness
good
more
point.
than
Excellent,
distal
excellent.
weakness.
Because proximal more than distal is not a classical UMN pattern. It is more of a element pattern.
Element.
Especially one of our first DDs has got that classical pattern. So that really helps. But that is not here. The most important clue is one finding,
Sir,
which really closes the diagnosis almost.
bilateral involvement of only motor weakness, but there was absent sensory involvement.
Sensory is there in the history.
But
Examination is not there. Right.
yes, sir.
Okay,
And
you can analyze. Forget about what I think. It is not important. You can analyze. So you think it is more of element because of all these reasons, right?
yes, sir. And mental functions were also normal.
Right. So it is not abscess.
Yes.
Okay. Right.
What about the cranial nerves? How does that contribute?
That is the most important, right?
Bilateral involvement of cranial nerves and other being all normal is more indicative of LMN lesion.
Why do you say it is? Why can't it be human? Why can't it be pondine?
Sir, other cranial nerves will be involved and usually there'll be unilateral involvement.
Correct. See, that is the greatest clue here, right? So there is bilateral facial involvement without any long tract. In the brainstem, there is no other cranial nerve involvement. Bilaterally affected means that has to be a big lesion in the pons. And in that case, there should be some amount of cerebellar involvement or some of this long tract spine sensory should be involved. So bilateral facial nerve is the big point in favor of an element syndrome here. Of course, all the element reflex, everything helps you. Of course, those things help you, but that really things, because if it is a UMN, you have to localize the lesion in pons because you are getting bilateral facial nerve palsy, right?
Yes.
So that you have to localize it there. So that is the biggest point here. Again, you have to check for the eye closure specifically whether it is element, which is not mentioned here. So that really pushes you to element. Okay, if it is element, what is your diagnosis now?
Sir, right now, most likely diagnosis is Guillain-Barré syndrome.
Yeah, that is your etiology, polyradiculopathy.
Polyradiculopathy.
Right?
Yes.
So after examination, do you want to still consider peripheral neuropathy or is it something against that?
Sir, sensory involvement was absent on examination.
Very good. So that is very much against a peripheral
neuropathy.
Okay. So peripheral neuropathy again, length dependent, usually distal more weak than proximal. Here it is proximal. So that is the biggest point against. Now, even if it is a very severe sort of peripheral neuropathy, sometimes the sort of weakness, pattern weakness may be misleading. But then if it is severe peripheral neuropathy, you definitely have some amount of sensory involvement. And then other possibility will be a pure motor type of peripheral neuropathy, and that presenting as in 2-3 days, this sort of weakness is very unlikely. So finally, you end up with what? Polyradiculoneuropathy. So remember, in GBS, it's not only peripheral nerve, it's not only the root, it is the peripheral nerve also that is affecting here. So you think it is a polyradiculoneuropathy, and because it being acute, more likely to be
AIDP.
Okay, what do you think the etiology is? Or is there any precipitating factor in the history or something?
In this patient, there was no antecedent precipitating factor. So this is idiopathic in GBS. But usually in 70% of the patients, they have antecedent upper respiratory tract or diarrhea-like illness.
70 is a big percentage.
2/3 of them.
Okay. So which other cranial nerves can be involved in GBS?
Sir, we can have ophthalmoplegia because of involvement of oculomotor nerve, but that is only seen in 15% of patients. And they can have signs of regurgitation because of glossopharyngeal nerve involvement, but that is also is seen in lesser patients. Facial nerve involvement is seen in up to 30% of GBS patients.
You are a very percentage man.
Highly fond of percentages.
Okay.
And
so
this patient had no history surgery of any facial nerve involvement, isn't it? From the history,
yes,
could you get any?
No history of facial nerve involvement.
And why such a disparity? What might have happened? why the patient is having on examination, there are some findings, but history, totally the symptoms were missed.
Sir, since it is ascending type of paralysis, maybe it is the initial stage where the patient did not notice and subtle signs were found on examination.
So what will be the signs which you can get when a patient is having bilateral LMN facial palsy? How do you pick up that?
Sir, loss of nasolabial folds bilaterally, um, um, inability to close the eyelids both sides, and there will not be any mouth deviation associated with this.
That's the point, right? That's what point Dr. Shamir want to ask you, because it's very easy to miss because there is no facial deviation.
Yes.
Okay, so if you don't specifically look for eye closure weakness, you will miss it. So that is the only examination most of the time I do when somebody comes with ascending quadriparesis. Just look at the facial palsy. I'm not telling you to do that, but that really gives the clue, because it cannot be anything else at that point. Okay, how you want to evaluate this case?
Sir, we'll have to send general investigations in this, because he's an
You can go for specific investigations.
in specific investigations.
Okay.
Nerve.
Okay, well, because you told general, if you are asked to send one general investigation, which one will you send?
Sir, potassium levels.
Excellent, because there was no
Hypo.
sensory after examination, right? So
Yes.
that's a bit of an odd for a true GBS, though it can occur, because when it is pure motor, you have to think of hypokalemic paralysis. Excellent. Very good. Right, now that you have finished your potassium, what specific investigation will you do to confirm your diagnosis?
Just number 7. You have 5 minutes left.
Okay. On CSF examination, we get albuminocytologic dissociation.
So this patient has come with
Is
3
it-
days history of GBS. You
Yes,
want to
sir.
go ahead with
Is there a
CSF?
time for an LF?
It usually 1 week later CSF
So
manifestation.
you can tell the specific specific diagnostic test which can be done at this point of time.
Sir, nerve conduction study.
Okay, what will you expect?
In a demyelinating neuropathy, the conduction velocity will be reduced.
Okay.
And
Very good. You're right.
we, like in CSF, other findings would be to look for.
Regarding the nerve conduction study, see, this patient has got 3 days history. So like the CSF, the nerve conduction study will also take some time. So this
Yes,
patient had a normal conduction velocity, normal amplitude. What
sir.
specific thing in nerve conduction? It's a difficult question, but if you can tell that, you will get
But that's a final question.
bonus points. So what is the earliest finding in nerve conduction study you expect in a patient with GPS? It's a tough question.
Is it the absence of the sensory waves, C maps, and
No, CMAP is for motor. Yeah.
Okay.
Have you heard of something known as F waves?
F wave? Yes, sir.
Yeah, it's a prolongation of F waves. Okay. So this patient had got a prolongation of F wave. Okay. You went ahead and you did a CSF study which showed what is the finding in CSF?
Sir, protein will be increased, but cells will be normal or less than 5.
So there is an albuminocytological, right?
Yes.
Okay. Now this is a patient who is a 13-year-old female. What
Yes,
specific
sir.
thing you will consider? Any what are the DDs you will have at this point? For
Sir,
radiculoneuropathy, what are the DDs you should consider? One you
vasculitis.
already told, hypokalemic paralysis. Okay, so that is one possibility.
Yes, sir.
What are the other DDs?
We will have to rule it out from other vasculitis presenting in the form of polyradiculoneuropathy.
Which are they?
Sir, usually polyarthritis nodos or Shirk-Strauss can have such polyneuropathy presentation.
Okay, peripheral neuropathy. Okay, right. Okay,
Yes.
then. Again, you
Then,
told that you are not considering peripheral neuropathy here because there is all the sensory thing.
yes,
Which are
sir.
the other DDs for polyradiculopathy which you consider in this sort of scenario, or polyradiculoneuropathies? I told a specific female with a 14-year-old recently started menarche. Abdominal pain is there.
Porphyria.
Okay, so will you test for porphyria?
Sir, spot urine porphobilinogen levels can be tested.
Okay, what are the other DDs you want to consider other than hypokalemia, porphyria?
other DDs here, we might have to rule out uh, vitamin deficiencies.
Which vitamin produce this sort of acute scenario?
So
I think
thiamine deficiency can.
oh, thiamine produce something known as global confusion, ophthalmoplegia, and ataxia. Wernicke is
Yes,
right.
yes,
I
sir.
think we are run out of time. One last question: what will you treat this patient?
Sir, either plasma exchange or intravenous immunoglobulin.
Okay, you are expecting positive response, right?
Pardon?
For the patient. You are
Yes, sir.
expecting,
Yes, sir. Because within 1 week of presentation, they have come for admission.
yeah, we expect positive response for you as well. All the best. Well done.
Okay,
Thank you.
thank you.
Right.
Thank
Well
you.
presented. Very nice. Okay, congrats.
Thank you, chess number 7. Sir, shall we let in the next participant?
Yes, sure.
Chess number 7, you can lead the meeting. Sir, the next chess number will join us shortly. I think they are having some network problems. They'll join us shortly.
Right. Dr. Shamir, the future looks bright.
Of course. Medical
Way better
education.
than we used to be, right?
eh, in spite of all this online teaching and COVID period,
Right.
logical thinking.
All have done well.
Sir, the next chess number will enter.
Okay.
Good afternoon, chess number 8. Can you please switch on your audio?
Yes. Is my number visible?
Yeah.
Yeah, it's okay. It's okay.
Yes.
Yeah.
Okay.
That's soon.
Yeah, you are very well visible.
Okay.
Chess number 8, you'll have a total of 30 minutes. At 25 minutes, I'll be giving you a warning call, okay?
Okay.
Sir?
Okay. Good afternoon. Are you
Good
ready?
afternoon, sir. Yes, sir.
Okay. So we'll be having a short presentation of the history first. Then we will
Okay,
be
sir.
having a discussion after that. Then we'll go to the examination and the final discussion. Okay. This is planned in such a way. Okay. So you relax and present. Okay. All the best.
Yeah, all the best. Carry on.
So is my slide visible?
Yes,
Yeah.
yes, yes.
Carry on.
So I'm presenting a piece of Mrs. Pankayakshi, 70 years old female, presenting hailing from Thalassery. The history is from herself and it is reliable. The presenting complaints are exacerbation of breathlessness and palpitations for 1 year and fever for 2 weeks. As the patient was apparently asymptomatic, until the patient developed breathlessness since past 3 years, she started experiencing exacerbations for the past 1 year. It was initially present only while climbing upstairs or going uphill, but now it's present even at rest. It is also exacerbated on lying down. 3 months back, she had two episodes of waking up after 2 to 3 hours of sleep due to breathlessness. She also complains of increased awareness of her own heartbeats for past 3 years, especially during exertion, but she kept ignoring it. Now it has become more disturbing since the past 3 months. Last 2 weeks, she feels a low-grade fever with increased tiredness and loss of appetite. No history of cough, hemoptysis, no history of wheezing or weight loss, no history of increased sweating, heat or cold intolerance, no history of weight gain or constipation, no history of drug intake, no history of recurrent respiratory tract infections, no history of swelling of legs, no history of oliguria, no history of abdominal distension or abdominal pain, no history of sensory or motor impairment, blurring of vision, seizures, or altered sensorium. Going to the past history, she has history of breathlessness for the past 3 years and was on homeopathic medication for past 2 years. She had an episode of right-sided weakness 1 month back, from which she recovered in few days. No history of diabetes mellitus, hypertension, dyslipidemia. No history of fever with fleeting joint pain and swellings, involuntary movements, skin rashes or nodules. No history of coronary artery disease, TB or syphilis. No history of any photosensitivity. No history of any other congenital cardiac problems. Coming to personal history, regular bowel and bladder habits, decreased sleep for the past 3 years, no history of passive smoking. Family history, no significant family history. Menstrual history, she is a mother of 4 children and attained menopause at the age of 52. She belongs to a middle class family. So,
Okay, so you can just summarize and explain each symptom.
okay, sir. Sir, 70 years old female presented with complaints of breathlessness for the past 3 years with exacerbation of breathlessness in the last 1 year, and patient also complains of symptoms suggestive of orthopnea and paroxysmal nocturnal dyspnea. The patient also complains of uh, palpitations and gives no other history, and also a low grade fever with decreased appetite and loss of weight. There is no other history suggestive of left heart failure or any other history suggestive of and also there is a significant past history of uh, past history suggestive of an embolic stroke episode, and there is no other history of ischemic heart disease or congenital heart disease or any history of active rheumatic fever or past history of rheumatic heart
So
disease.
how do you want to explain each symptom? What is causing the breathlessness?
Sir, breathlessness is can be caused by it's a cardinal symptom of the cardiovascular system. So any kind of like
Why do you consider this breathlessness as of a cardiac origin?
so because it's gradually increasing from the it was first on exertion, then it just progressed to paroxysmal nocturnal dyspnea, and then gradually progressed to rest and exacerbated on lying down. This is classical of cardiac pathology.
Okay. So what is causing this dyspnea in cardiovascular system?
Sir, the pulmonary venous congestion is the basic pathology. Any LV systolic failure or any like increased LV end diastolic pressure can also reflect the same pressures to the pulmonary venous system, and this pulmonary venous congestion actually
So
leads to
which one do you consider here? Is it a left
sir,
ventricular dysfunction or something
Sir,
else?
I will first consider a left ventricular dysfunction, not a dysfunction. I will consider a LA, left atrial pathology first here, because there is a history suggestive of like gradual progression, and there is history suggestive of embolic episode. So I
So
will
you will
like to consider.
a left atrial pathology.
Yes, sir.
Left atrial pathology.
Yes, sir.
So what are the common left atrial pathologies which can present like this?
Sir, mitral stenosis can present like this, but palpitations won't be there unless atrial fibrillation develops, and most likely it will be a mitral regurgitation, which can
Okay.
present like this.
So you are considering a mitral regurgitation first.
Yes, sir.
Okay. So before going to the etiology proper, we will analyze the second symptom. So it may help us, isn't it?
Okay,
So
sir.
for the with regard to the breathlessness problem, we are considering a left atrial problem as a predominant one, which may be caused by a regurgitant lesion. Okay. So next one, palpitation.
So palpitations can suggest two things. Most common is it can be either a case of volume overload or it can be a arrhythmia that is occurring. But in cases of, she complains that she is suffering from this palpitation since 3 years, and it's more or less continuous. So we can whereas arrhythmias will mostly be like intermittent kind of arrhythmias, and but the rest of the history of palpitations is not like given, whether it's regular or irregular. She's having some bounding sensation
Okay.
of missed beats. These are not given, so
Okay.
we can assume from the like chronicity that it's a volume overload lesion.
Okay. So what are the possibilities? If it is volume overload,
Sir, again, volume overload, it can be a mitral regurgitation, and coming other causes may be an aortic regurgitation. It might be a like ventricular septal defect or a patent ductus arteriosus, but age is like not fitting.
Can you think
Okay.
of other non-cardiac causes for volume overload?
Yes, sir. Non-cardiac causes can be there, like severe anemia might be there. In this patient, she might be suffering from thyrotoxicosis, and then anemia. Pregnancy can also, but the age is not
so
perfect.
with
So,
regard to the palpitation, you consider it as a volume overload condition, and
yes,
it
sir.
can be a non-cardiac or cardiac. Among those, you prefer a cardiac condition here, and among the
Yes,
cardiac volume overload, you prefer a volume overload because of the regurgitant lesion. Okay,
yes, sir.
so that is the final take in the palpitation. And with
Yes, sir.
regard to the breathlessness, you consider it as a left atrial pathology due to
Yes, sir.
again a mitral regurgitation. Okay.
Yes, sir.
Any other possibilities you can think of, like left ventricular pathology or some other valvular lesions? Is it
Yes, sir.
possible?
Yes, sir. An aortic regurgitation can also have a like similar presentation. It can have palpitations and breathlessness, exertional dyspnea, because the LV end diastolic pressure is increased here. So we can have this kind of lesions, but there are
So
no other.
what is against an aortic regurgitation here?
Sir, like there are no episodes of she does not report any head bounding. Then an aortic regurgitation won't have that much of LA enlargement, left atrial enlargement, and mitral regurgitation is more associated with
What is
embolism.
so evident that is it a must that this patient should have a LA enlargement?
No, sir.
Is there some clue like that? Then
No, sir.
why you are obsessed with the left atrium? Why it cannot be a left ventricle?
So it can be, but there are no symptoms suggestive of LV systolic failure.
So what other symptoms you want? There is already an exertional dyspnea. There is already a worsening of dyspnea over the last 3 months. Patient has history of wakening from sleep due to breathlessness. You yourself were telling there is an orthopnea. Then why it cannot be a left ventricular dysfunction?
Sir, there is no history of oliguria. Then there is no history of right heart failure is not there.
You mean to say there is no features of a forward failure?
Yes, yes, sir. No features of a forward failure.
But then the patient has got some syncope or something, pre-syncope or something, right?
Sir, she had an episode of right-sided weakness.
Okay.
Okay.
And according to that,
I think that is the sole reason why you are considering this left atrium as the predominant
Yes,
region.
yes, sir.
Because you want an atrial fibrillation.
You want a focus for embolism. So you
Yes,
think
sir.
that embolism can occur only from left atrium?
So, no, sir. It can also occur from left ventricle.
How?
Sir, if there is LV dilatation, is there any dilatation or like a mural thrombi might be formed in a dilated LV, or if there had been a previous episode of like myocardial infarction, LV aneurysm could also
So
be
it's also possible. So left ventricle can also be a focus for a thrombus, and it can embolize to produce a stroke also. So that does not exclude a left ventricular disease here, isn't it?
Yes.
Okay,
Yes.
putting all these things together at this age with only 3 years symptoms, what will be the most fitting etiology here?
Sir, the most fitting etiology in this patient who is 70 years old, I would like to consider like a mitral regurgitation, probably of degenerative etiology.
Degeneration means, can you specify what kind of degeneration?
Calcific degeneration.
Calcific degeneration. Okay. What are the other causes of mitral regurgitation in this age group?
So other causes might be ischemic cardiomyopathy might be there. It might be post myocardial infarction. Then it can be in this patient, it can be due to a dilated cardiomyopathy.
Okay, okay.
In our
among
country, what
these-
is the commonest cause? In our country, what is the commonest cause?
Sir, in our country, it's a rheumatic like heart disease is the most common cause.
Always consider that possibility, and in that
Yes, sir.
scenario, you can get multiple valves involvement as well, right?
Yes, sir. Yes, sir.
Okay, let's see the examination findings and confirm our possibilities, isn't it? Okay.
Okay, sir.
Okay.
Definitely.
Continue.
The patient is conscious and oriented. The patient. Patient is conscious and oriented, moderately built and nourished. Pallor is present. No icterus, cyanosis, clubbing, lymphadenopathy, or edema. Clean hairs, nails are normal. No thyroid swelling or varicose vein. No xanthelasma. Arcus senilis is present. No peripheral signs of aortic regurgitation. No features of hyper or hypothyroidism. Coming to vitals, pulse is 70 beats per minute, regular rhythm, low volume, normal character. Blood pressure, 110 by 80 millimeter mercury for right arm supine position, 130 by 90 millimeter mercury in right lower limb in prone position. Respiration rate is 18 per minute, regular. Temperature is febrile. Coming to cardiovascular examination, JVP is not elevated. On inspection, apical impulse is observed to be on the lateral to mid-clavicular line. Shape of precordium is normal. There are visible pulsations over suprasternal area. No dilated veins, scars, or sinuses. Palpation. Apex beat is felt in left fifth intercostal space, 2 centimeter lateral to mid-clavicular line, heaving in type, no parasternal heave. Systolic thrill is present in aortic area. Suprasternal pulsations are palpable. Percussion. Second intercostal space is resonant. Left heart border corresponds to apex beat, and right heart border corresponds to right sternal margin. Left heart border corresponds to the apex beat. So liver dullness is at fifth intercostal space in mid-clavicular line. Auscultation. Since I got the maximum intensity of murmur in the aortic area, I would like to start with aortic area. Aortic area S1 and S2 are muffled. Harsh crescendo decrescendo ejection systolic murmur of grade 4 intensity was heard at expiration with diaphragm of stethoscope with patient in sitting and leaning forward position. Murmur radiates to root of the neck. No S3, S4 or additional sounds. Pulmonary area. S1 and S2 are muffled. Harsh crescendo decrescendo ejection systolic murmur of grade 4 intensity was heard at expiration with diaphragm of stethoscope with patient in sitting and leaning forward position with reduced intensity. No S3, S4 or additional sounds. Second aortic area, an early diastolic murmur heard with patient sitting and leaning forward, breath held in expiration. Mitral area, S1 heard but S2 muffled. The above murmur was heard with reduced intensity. No S3, S4 or additional sounds. Tricuspid area, S1 and S2 heard. The above murmur was heard with reduced intensity. No S3, S4 or additional sounds. Coming to examination of respiratory system, trachea is central, chest movements bilaterally equal, all lung areas are bilaterally equally resonant, no vesicular breath sounds, no rhonchi, wheeze, or crepitations. Examination of GI system, abdomen is flat, umbilicus central and inverted, no dilated veins or scars, no organomegaly, no shifting dullness, normal bowel sounds heard. Examination of nervous system, higher functions
Everything
are
normal,
not.
isn't it? There is no abnormal findings.
No abnormal findings, sir.
Okay, so we'll go back to the cardiovascular system and general examination. So, what do you think now? You had something in your mind after the history, and
Yes,
after
sir.
examination, how does it support your history findings? Is it contradicting your history?
Sir,
What do you think now?
yes, sir. I would. I coming because my predominantly I thought of a mitral regurgitation. My examination findings did not support it. So, what the examination revealed was basically a like in the inspection part, I could feel that the like apex was lateral to the mid clavicular line, which was consistent with an LV hypertrophy. And now coming to palpation, the LV apex beat was again
If it was a
lateral.
mitral regurgitation, what would you have anticipated in the general examination?
Sir, in a mitral regurgitation, we would have found uh, an LV like apex would have been downwards and
In general
outwards.
examination, what would you have anticipated in general examination? In the
Sir,
vital examination, pulse, BP,
sir,
etc.
yes, a vital examination. We might have found a increased pulse pressure might have been found, but with normal volume.
Okay, so it's not supporting your mitral regurgitation. Can you get a
Yes,
normal volume pulse, and normal BP in a mitral regurgitation?
yes, sir. We can get, sir.
When?
So unless the patient is in like left ventricular failure, we will get a MR, and if it's again like it's not in failure, then we would obviously get like normal BP, and pulse is would also be, and if there is AS
So
associated
what
with
do you
it.
think? No, if it was a mitral regurgitation and with all these symptoms, what do you think? Is it a mild MR or it's a severe MR? What do you think from the history? Suppose
So
it is an MR with all these symptoms. She had all features of failure. She had palpitations. With all those symptoms, what do you think? The status of MR would be a mild one or a moderate one or a severe one?
it's a severe one, sir.
Severe one. So what kind of blood pressure and pulse you expect there?
So in severe MR, we expect low blood pressure will be there, and pulse rate will be have high volume with low with a normal pulse pressure.
Okay, so in which kind of MR you can get a low volume pulse? Can you expect a mitral regurgitation with a low volume pulse?
So if it's associated with LV systolic dysfunction, like there
Okay,
was
very
an
good,
issue.
very good. Okay, very good. Okay. So with no change in pulse and BP, in volume of pulse is normal, blood pressure is normal, still the patient is having a severe MR. Can it happen like that?
Yes, sir, it can happen, especially in calcific type.
Is there something called a calcific MR?
So like it can be of degenerative etiology too in old age.
What will happen if there is an acute onset of MR?
So yes, acute onset of MR can have a like it's generally secondary to a inferior wall myocardial infarction. So it will have a a kind of a flash pulmonary edema will be there, and yes, the cardio it might lead to a cardiogenic shock too.
Okay, patient can have a severe manifestation of pulmonary edema when there is an acute MR also. And you need not
Yes,
get a characteristic findings of mitral
consistent.
regurgitation when you examine
Yes, sir.
the cardiovascular system. Okay. So in going proper cardiovascular system, the findings, what are the findings?
Sir, the apical impulse on inspection was lateral to mid
And
clavicular
what is
line,
the
and the
explanation for that? So what do you consider? There
so
is a cardiomegaly.
cardiomegaly is there. So
Yes.
and there are visible pulsations over suprasternal area. So
Okay.
this suggests an aortic etiology here. So
Okay.
maybe an aortic regurgitation or an aortic root disease.
Okay.
So, sir, coming to palpation, the apex bit is of it's only deviated outwards, not downwards, and it's heaving in type, suggestive that it is a kind of pressure overload.
Okay. Very good.
So, and there is a systolic thrill in aortic area, suggestive that there is a systolic murmur of at least grade 4 in intensity.
Okay. All
And
these
again,
things confirm the presence of a
aortic stenosis.
aortic stenosis. Okay. Then
So then percussion again, it was consistent with my findings, like there was no RV hypertrophy here, and the left heart border corresponded to the apex beat. And second intercostal space resonant depicts that there is like no pulmonary arterial hypertension.
Okay.
Sir, here again auscultation, the murmur was highest in the aortic area, so I started with that, and there was a
No,
harsh
you did
threshold
not explain all those things again. The murmur, the apex examination, everything is history of an
Yes, sir.
aortic stenosis. What else?
Sir, again, when I came to the neo-aortic or second aortic area, there was uh, an early diastolic murmur with the patient sitting and leaning forward, breath held in expiration. It was more prominent. So it suggests that it is an aortic regurgitation.
Okay. So now you have a combination of aortic stenosis and aortic regurgitation.
Yes,
Okay.
sir.
Anything else?
No, sir. Like the examination of RS system, I would look for like if there are any bilateral crepitations are present, that would like indicate a presence of congestive cardiac failure, but they are not present right now. So the patient is most likely not in failure right now, and the abdomen rules out any organomegaly.
Okay, there is no other finding given in the presentation. So if you are allowed to examine the patient, so what else you want to look for?
Sir, I would like to look for peripheral peripheral signs of aortic regurgitation. I would like to
What will you do?
Sir, I would do a head to toe examination for all the peripheral signs of aortic regurgitation, and in pulse there is no mentioning of any vessel wall thickening, which might.
Hello?
Sir, I am audible.
Yeah.
Yeah, in between we lost for a few seconds. You can continue. Now
Yes,
it's
sir.
okay. Yeah.
But in pulse, there is no mention of vessel wall thickening. So if the vessel wall is thickened, it's more confirmatory that the pathology is degenerative, and also if there is a vessel wall thickening, we cannot appreciate a typical slow rising pulse of AS.
Okay, what else will you examine?
Sir, for
You are given a chance to examine in detail, and any other sign will you look for which are not mentioned in this presentation?
Sir, yes, sir. I would like to rule out evidence of pulmonary hypertension. Like no, like if there is any palpable P2 is there, or
It's already given. The second intercostal space and there is no palpable pulsation there, auscultation, everything is given.
Yes, sir.
What else you want?
So, sir, I'll also look for any other peripheral signs of infective endocarditis in this case.
Why it is important?
Sir, because in infective endocarditis, we have to manage the infective endocarditis first.
Why
And
it is important in this patient?
So because this patient is suffering for fever, and there has been a recent exacerbation of symptoms for the last palpitations for the last 3 months.
That's a very important symptom. Then why you
yes,
are
sir.
not giving any consideration to fever till now in the history also? So when a patient like this presents with fever, okay.
So when my full diagnosis would be there, I would like to consider the probable evidence.
So what are the signs will you look for?
Sir, in infective endocarditis, I will look for immunological phenomenon like oscillatory nodes, rot spots, then vascular phenomenon like any embolic gangrene is there, some splinter hemorrhages are there, or there are any evidence of Janeway lesions. I will look at those things, and splenomegaly can also be a feature of
very good.
SAB.
And what else if you want to assess the severity of AR?
Yes, sir.
What additional examination will you do?
The severity of AR, I will do the increased pulse pressure. I would do the Corrigan Waterhammer pulse test, so to examine the severity of AR, and the Hill sign. I would like to especially check for Hill sign.
What is Hill sign?
So Hill sign is basically the left lower limb blood pressure is at least more than 20 millimeter mercury compared to the upper limb. Sorry.
Okay, so now you are thinking the patient is having an ASAR and a possible infective endocarditis. Is it so?
Yes, sir.
And what might be the etiology of
So
ASAR?
the etiology, I would still like to consider like degenerative etiology here.
Degenerative etiology. So
Yes, sir.
how can you, is there any reasonable explanation for the recent hemiparesis or hemiplegia which the patient had 1 month back?
So it was 1 year back, I think. So
1 month back.
okay, 1 month back, sir, it might have been a like subacute infective endocarditis, which would have been throwing emboli, but she did not notice the fever much. It might have occurred.
Excuse me, chest number 8, you have 5 minutes left.
What are the possible mechanisms by which an infective endocarditis can lead to a neurological manifestation?
Sir, it might be like an septic emboli might be there. It might
Oh,
be
good.
yes, sir.
Okay, very good. Continue.
Intracranial hemorrhage might be there. She might have been undergoing some previous anticoagulation. So we have to suspect a hemorrhage if she's on previous medical therapy. Then it might be a rupture.
That is a very wild guess. Directly related to infective endocarditis.
Sir, it might be a mycotic aneurysm.
Okay, very good. Anything else?
So no, sir. Like if the medications can also lead to the hemorrhages. That's all. Like it can lead to.
Which medication in infective endocarditis can lead to hemorrhage?
Sir, when the patient is on like warfarin and like heparin, those things we will consider. The patient might have been on. If it had been a rheumatic etiology, she might have been on anticoagulation.
Do you expect an anticoagulation in all rheumatic heart diseases?
No, sir. No, sir. It's only for if there is like rheumatic like atrial fibrillation is there, then we would like to consider.
There is no reason to consider an atrial fibrillation here, isn't it?
Yes, sir. Yes, sir.
Is there any particular reason for that? It is unlikely the patient is getting an anticoagulant in this scenario.
Yes, sir.
If
In
she
this
is on
scenario,
anticoagulant, it's okay. Is there
yes,
any
sir.
other reasons? What can lead to this septic embolism can lead to what all complications?
So septic embolism can lead to a like pulmonary infarct might be there, or there might be a splenic infarct, or there might be a like embolism to the extremities, and it can lead to a wet gangrene rather than a dry gangrene.
Okay. Krishnadas.
Yeah, what is the commonest cause for a aneurysm, that mycotic aneurysm?
Sir, Staphylococcus aureus.
Okay, right. It has nothing to do with fungus, right?
No, sir. It's got nothing to do with fungus.
Can fungus produce it?
Yes, sir. Fungus can produce it. Candida and histoplasma has been like found to cause it.
Right.
So what all investigations you want to do in this patient?
So in this patient, first I would like to do like echocardiography to confirm my diagnosis. I can also do a chest X-ray to like visualize if there is, and ECG to like confirm the LV and LA enlargement and the rhythm of the patient. And I would like to consider like blood culture in this case to confirm my diagnosis of like AR, both basis on echocardiography and blood culture. I can come to a diagnosis if both are positive.
Okay. So how will you manage?
So management, I will first like treat the infective endocarditis here first, because it's a native valve endocarditis. It's the most common cause will be a staphylococcal like coagulase negative one here. So so I would like to consider to treat the patient with antibiotics after confirming the diagnosis, because it's a subacute one. We can wait till the diagnosis has come. So then we will start him on antibiotic, preferably a like a third generation cephalosporin, or we can use a penicillin if she's not hypersensitive. So we'll go
Is
with
there
4 to
any
6.
role for surgery here?
So yes, sir, because we have to first stabilize the patient, and because the patient is so severe and symptomatic, having like severe AS and AR, so we will consider here surgery here, aortic valve replacement.
What are the indications? Because she is having a severe AS or severe AR or something else.
Yes, sir. Because she's having severe and symptomatic, especially she's symptomatic. She's having severe. other indications might have been an like LV ejection systolic fraction would have been less than 50%, then also we would also have gone for a surgery, even if she was asymptomatic.
So what are the role of surgery in an infective endocarditis?
Sir, whenever we have a like cardiac complication like abscess, some fistula is there, or if there is any perforation of cusps, or there is a dehiscence of already prosthetic valve, placed prosthetic valve, then we have to like go for surgery. Or when there is like a culture negative endocarditis is there and it's resistant to all our therapy, so we can go for a like valvular surgery there in
Okay.
those cases.
Okay. That's all very good. Nice
Good.
presentation.
Nice.
Thank you.
Well done.
Thank you.
Thank you.
Thank you, chess number 8. You may now leave the meeting.
ഇതാ ഞാൻ തന്നെ രണ്ടെണ്ണം.
So, thank you all. Thank you, dear judges, participants, and my dear audience. I hope you enjoyed today's session. I would like to express my deep regards to the amazing judging panel that we had today. Thank you, Dr. Krishnadas sir, Associate Professor of Neurology, MES Medical College, Perindalmanna.
Thank you.
Thank you, Dr. Shamir sir, Assistant Professor of the Department of General Medicine, Government Medical College, Kozhikode. And I would also like to thank all the participants for their enthusiasm and the support that they have shown. We had an initial of 130 entries for medicine case presentation. 40 were selected for the prelims and 8 made to the finals. So that concludes this session. Thank you.